good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. Today we're exploring asthma, one of the most common and costly and chronic lung diseases. With the right knowledge and medication, people with asthma can live healthier, more active lifestyles, but managing asthma can be a challenge, especially when air quality drops, the humidity goes up, the temperature goes up, or allergies pick up, or standard therapies stop working. There are also millions of children living with asthma. Have you ever tried to get a toddler to use an inhaler? We're going to meet a mom who had to learn how to do just that. I'm joined today by one of the most illustrious panels we've had, except for my good friend on the right, Dr. Mario Castro, the Health Systems Division Chief of Pulmonary Critical Care and Sleep Medicine. Just kidding. Very illustrious.
Thanks.
He is an asthma expert involved in a lot of research, both in advocacy and on the national level, including working with groups like the CDC, the NIH, and the American Lung Association. Dr. Selena Geyer is an allergist and immunologist here at the health system. She reminded me, she was one of the residents I trained here long ago. She's going to help us understand how asthma and allergies overlap. And on the pediatric side, Dr. Sean Sood is a pediatric critical care physician here at the health system. Now, we're also joined via webcam by Leah Hostetter and Haley Wank. Leah's baby Charlotte has been hospitalized for breathing problems before, but now is on daily medication. Haley has been living with severe allergies and asthma for years. We're going to be glad to hear your all stories in just a few moments. First, some quick asthma facts. It's a chronic disease that currently has no cure. It affects an estimated 27 million people in the United States, or roughly 1 in 12 people, and that includes 4.5 million children and adolescents. Asthma makes it hard to breathe because it inflames your airways. The airways get thicker, there's less room for airflow. Allergens and irritants can make the inflammation around the airway worse, and over time, asthma can remodel your airways, permanently making it more narrow and reducing your lung function. Okay, now I get to start talking to all these good experts. Dr. Castro. Now, we could treat asthma symptoms. Why can't we cure asthma? And first of all, asthma, is it really one disease, or is it a whole bunch of diseases?
Well, that's a great point. The first thing is that it is many different diseases. You know, we have some patients that allergies are a big driver of them, but there are other patients where allergies is really not such a problem for them. And there's other things that we need to address to get their asthma under control. To answer the first question, though, we're almost there, Steve.
Oh, listen to you. That's great, man. I'm holding it. What's your timeline? Noon? 4 o'clock?
We are excited that with some of the newest personalized medicine approaches that we're actually getting about 1 out of 5 patients into remission.
That's impressive.
And we may not get a cure yet, but we are getting people into remission, which when you think about remission, it means that your disease is under control. You're not having to go to the emergency room in the hospital, and you're just taking a minimal amount of medication to keep it in check. And so that's our ultimate goal, is to really preserve that quality of life for our patients, get them back to doing what they want to do, their sports, their work, and their activities, and that's now possible.
Yeah, that's an impressive statement to be able to do that. You're catching up to cystic fibrosis then, sort of, in personalized medicine. No, let me hang here. All right, there you go. All right, some people live with uncontrolled asthma. What are the biggest barriers to trying to control it?
Biggest barriers to control, one, is access. Access, because it's not only just access to health services like KU's system, but it's also getting access to the medications. We really have a difficult situation where some of these medicines are costing our patients $300 to $400 for a single inhaler every month. And the cost of asthma medications is really high and of concern for us for such a common chronic disease. Other barriers are really just trying to get the environment right. Mm-hmm. You know, it's not only just the indoor environment, which we experience every day, but also the outdoor environment. And we've now known that these things are continuous triggers. There was an analogy that if you think about how much air you're taking into the lungs each day, it would fill one of those huge concrete dumpsters, about 11,000 gallons of air that you have to take in. And imagine how your body has to handle that every day. And so the environment is a huge issue for our patients and can be a barrier for some patients. I've had some patients said, I've not been able to move out of my house. I've kind of kept the COVID pandemic inside my house and stayed there since then because my asthma goes out of control when I go out. So we have to identify them, what's triggering their asthma, and address that etiology with our colleagues in allergy. We're able to often identify exactly what that is and then really tackle that for our patients.
So did you just say that the air that I breathe, which yes is a popular song, but I won't sing it, I'll save our audience from that. Did you just compare that to a dumpster? Because I think
Yes.
you did. I think you just compared that. So what's the impact of global warming? I bet it's probably not good.
Global warming is a huge issue for our patients, and fortunately, our patients realize that the minute they step out that door. I've had patients said, Dr. Castro, it hits me like an oven and I can't breathe. And so I ask them, keep an app on or keep, some tack of, hit the morning news and try to figure out, is it okay for me to walk out, or do I need to kind of do something to prepare for, maybe take my inhaler before I walk out into that hot, humid weather. Those are things that our patients can do to prepare better for seasons that we're having right now.
Air quality index.
Air quality index. Keep an eye on it. I like the green zone, but unfortunately we're not there.
We don't see it so much. Okay, Dr. Kyer. Asthma involves the immune system, but it's not just an autoimmune disease, right? Help us understand the difference and the overlap with asthma, allergies, immune response, and all of the above.
Sure, so that's a great question. The immune response can be broad, and so when we think of the immune response in asthma, it is usually the allergic part, not an autoimmune disease in general, but more of an overwhelming inflammation generated by exposures that you have in a day-to-day basis. So for example, cat dander or dust mite, which is the part of house dust you're allergic to, that induces a chemical cascade that induces inflammation in the chest that causes asthma symptoms. So it's that part of your immune system that is sort of overactive more than it should be.
So my cat is Hoshi. Hoshi's listening to the program today. I think you just made her feel badly.
Yes.
But this thing about animals and people, there's such an important relationship.
Sure.
But when it starts causing you to have trouble for breathing, what do you say to patients?
Yeah, people don't get rid of their pets. They are family members.
Their family. My cat's part of the family.
Right.
Well, my wife will not let it in bed. Out, cat. But, yeah.
Obviously, our first instruction to the patient is avoidance of their triggers. And if they can't get rid of their animal, then we use medications to help them, allergy immunotherapy or allergy shots to help their immune system reverse that sensitivity to cat dander or dog dander or whatever animal is in there. And the medications are very helpful for keeping that asthma inflammation at bay, so they can continue to have their pet.
Yeah, that's a big deal. Now, Haley, how long have you lived with asthma? I mean, this has been a part of your life for a while, as I understand.
Yeah, I actually reached out to my mom last night to kind of jog my memory, and she shared with me that I think it was about 3 or 4 months old that I had my first bout of pneumonia. And then after that, it would be every so many months where I would have exacerbations, and then so forth. And then it's persisted my whole life, unfortunately. Okay,
so do you follow the air quality index as Dr. Castro has recommended?
No. No, I'm a mom of 3 and working full time, and no, I do what I can to get by. I have a daily maintenance inhaler. I'm on Advair, and then I also do take Allegra every day because I do notice that really impacts both my asthma and my allergies and my eczema that I have as well.
Yeah, so you have triggers though, and it sounds, I mean, if mother of 3, I can't imagine what you're doing to get rid of triggers, and they're bringing triggers to you all the time in the form of dirt and different things and viruses and stuff. How do you manage all that?
I think I'm really fortunate that my asthma, now that I've gotten into adulthood, isn't very well controlled. There was one point where I was on Xolair as well, but I got to be a bit too labor intensive with my work-life balance. Things are kind of settling down again, so I'm hopeful to resume, some type of biologic, but pretty much just sticking to my daily regimen has helped with that. I do have certain triggers like when I would go to my in-laws' house and they have a dog, despite me having a dog and a cat at home, I kind of become immune to them. But animals that I'm not as familiar with, I will have issues with. And so I'll just really make sure that I always have my rescue inhaler, which is my albuterol, with me at all times.
So you have an asthma action plan, I take it, that you have to follow when things start to get a little rocky?
I do. Again, fortunately, I'm so well controlled that it's not as much of an issue, but I do have an asthma action plan. I've always have my inhaler with me in my purse. I have one in my nightstand. I have one down on my treadmill in the basement. And then we do also have a nebulizer at home with several vials of albuterol available. I will say I probably have used that once in the last, I don't know, a couple years. If I get so bad that I'll then reach out to my primary care doctor to do a round of steroids.
All right, now on a bad asthma day, how much does it limit your activity?
Again, it's pretty well controlled now in adulthood, but I won't say it really affects like my ADLs, but I will definitely have to kind of pause a little bit. Coughing can sometimes be an issue, but otherwise it's not too much of an impact.
I'm struck by something she said. I just want to turn to you guys and just have us talk about this for just a moment. Work-life balance. Mm-hmm. That is any person with a chronic disease, that comes into play. How do you talk to your patients about that? Start with you.
Yeah, I think we talked about access, right? We talked about access having multiple issues. So one of those issues is making sure you can get to your medications, whether that is a biologic that you have to get an injection in your doctor's office. You have to get to your doctor's office to get that. And a working 8 to 5 Monday through Friday person cannot do that maybe. Allergy shots fall into that same category. She alluded to the fact that she has her inhalers everywhere she needs them, right? So making sure you have that medication at work if you need it. For kids in sports, making sure they have it at their sporting event if they need it. Those things to help you balance that helps to make sure that your asthma remains controlled.
Yeah, and Mario, you mentioned this work, the issues about affordability of medication, et cetera. Mm-hmm. Work-life balance, how does that all play together?
Yeah, well, Haley's very fortunate because actually a lot of my patients can't get extra inhalers to have available in other locations, and we have to advocate for that sometimes. I do think work-life balance, sometimes even work is the problem. I've had patients where I've had to write to their supervisor, to their boss, and say, hey, we can't be exposing our patient to fumes from the paint or dust that's in their environment because it's a big trigger for them. And so sometimes just reaching out to your physician and asking them to help be an advocate for you in that work environment can be helpful. But ultimately, we all have to do like Haley does, and we have to balance kind of what we're able to do and what we can't do and because of our chronic disease. But I do encourage patients that, we're in times of the Olympics right now, right? So I've had patients that are Olympic athletes, and you can function at a very high level, which is great because it is the ultimate goal for my patients. Is like, don't accept that you're short of breath just by walking out the door. Don't accept that. We want you to get back to a normal lifestyle, and you can with appropriate medication and advice from your physician.
That's awesome. All right, now asthma is a major concern for children. Dr. Stude, does asthma present differently in kids?
Yeah, there are key differences with pediatric asthma and adult asthma. Pediatric asthma has a more neutrophil predominance. Adult asthma has a more IgE or eosinophil predominance. And there's other differences too. In pediatric asthma, it's more male patients, and sometimes symptoms can be intermittent in nature. In adult patients with asthma, there's a more female predominance, and symptoms can be more persistent. And so adult patients may require their medication every single day, while sometimes in a subsection of kids, they can just require medications intermittently if they have an asthma attack or an exacerbation. And one of the key differences is how they fight asthma. So, our patients that we see in the pediatric ICU, they don't have the same collateral circulation in their lungs compared to adults do. So when we saw that animation with all that inflammation and edema that asthma causes, really that inflammation, children have a tough time to fight that inflammation because they don't have those collaterals or pop-off valves in their lungs to get ventilation in other areas of their lungs. And so just inherent physiological differences make asthma attacks different in severity for kids versus adults.
You know, it is, that's got to be tough. And you're a pediatric ICU doctor, so you see these folks when they're at their worst.
Correct.
Are there certain things that you say, this is what kind of leads kids to have to be under our care in the PICU? What kind of, is there a similar story at all?
We try to do a scoring system to see what certain triggers that child is around at home or at school. If a child can speak sentences, or they're just mumbling, saying a couple words that if I go down to the ER, I'm saying, wow, this child's really struggling to speak a full sentence. Right. They may need higher level of care here in the ICU. And so some common themes.
You bet. Let's bring in Leah. Leah, take us back to the summer of 2022. You were on vacation. You noticed something wrong with Charlotte's breathing. Can you describe what you were seeing and why you went to the emergency department?
Yeah, absolutely. So my daughter Charlotte was 9 months old at the time, and we had our first family vacation to Florida. And we noticed even before the vacation, she seemed a little off, and we attributed that to an ear infection. But when we were on vacation, we noticed that she was struggling breathing just a little bit, not significant enough at the time to really warrant calling 911, but just within a few hours, she started to stop eating, stop drinking. So we took her to the closest pediatric ER when we were in Florida, and she tested positive for RSV and ended up in the ICU for about a week to get her breathing under control.
Yeah, that respiratory syncytial virus, that's a bad, tough virus. And we were all alarmed by that. We're going to turn to Hawkeye in just a moment, talk a little bit more about that. But after that first ICU stay, did Charlotte's breathing return to normal?
It did not. So she has struggled with her breathing ever since then. She's actually had 2 more hospitalizations. She got another virus last year that hit her hard. And then in January of this year, she got RSV again and had to be hospitalized. And this most recent hospitalization in January is when she got put on an asthma action plan.
All right, so that's when she was diagnosed with asthma. Do those inhalers help her? How often does she have to use them? How hard is it to give it to a 5-month or 10-month-old?
Yeah, so thankfully she has adjusted over time. Some days are easier than others to actually give her inhaler. So in this video, this was an easy day. But it has been an adjustment. So she takes QVAR every single morning and every evening now. And then similar to Haley, we give her albuterol when needed. So we carry it with us at all times. She has it at daycare. We've instructed our family to have to administer it in case they're watching her whenever we're away. And then there's been a couple times where she's needed steroids as well as part of her asthma action plan.
Is she better? Can she run and play and do the things she wants to do?
She can, yes, and I'm very grateful for that.
So Dr. Castro, Dr. Stute, is there any way to predict if asthma, or Dr. Geyer, whoever, is there any way to predict if asthma in childhood is going to continue into adulthood? Because there's that story out there that says, oh yeah, you'll outgrow it.
So yes, there's this asthma predictive index that helps us understand if a child who has wheezing early on in their life will go on to have asthma later. These include things like a parent history of asthma, childhood, the child has tested positive for either food allergies or allergies in the air. There's some other markers that we can sometimes use to help us determine that. But ultimately, we sort of just clinically monitor our patient, and some kids will still wheeze and some kids will outgrow it. Parents always hold on to that they'll outgrow it. Yeah. But that's where your specialist, allergist, pulmonologist can come in and help determine if that child has a propensity to going on to have asthma long term.
Have you figured out why that is?
Well, it is Charlotte's case, and she's so beautiful, by the way. I'm so happy for you, Leah. Charlotte's case is really a common story. Unfortunately, most children are exposed to RSV in the first couple of years of life. We know that if you end up in the hospital like her, 60% of those children with RSV by age 6 will have asthma. 60%.
That's a big number.
That's a big number.
Yeah, and
so,
RSV's been around for, I assume, for a long time, so there's something wonky
It's been a long
something
time.
funny going on here.
And fortunate, and maybe Hawkeye can address this, we starting to now have vaccines, which we've been looking for these vaccines now for decades because this is such a common and potentially deadly virus. But Charlotte's story is very important because as Leah's recognized, you have to be able to advocate for your child. And when you start having those wheezing episodes, you need to get on those controller medications in order to control the disease so you don't end up in the hospital.
That's a big darn deal. And now, go
I
ahead.
will say that the majority of pediatric patients with asthma do outgrow asthma. About 70% of patients that I see at the age of 7 with asthma will not have asthma in adulthood. And so I do want to share a little bit of optimism that we can outgrow asthma, but definitely there is a subset of patients that persist into adulthood because of all these various factors.
Okay, so who am I going to blame that Flovent is not on the market anymore? That used to be a drug I used to love to use all the time. I mean, I've been around since the days we tried to convince people to use beclomethasone like 4 times a day or whatever. Then Flovent came out, changed this kind of stuff all over. But what happened?
Well, again, it gets back to the struggle that we're having with our asthma medications with our patients. It's not just Flovent. There are other medications that have been discontinued primarily because the pharmaceutical company making it no longer has the patent. And so then it starts becoming developed in a generic form. And in Flovent's case, a lot of the insurance companies weren't paying for the alternative, weren't paying for the generic form of it. And that makes a huge problem for our patients because now they don't have a medication. And so we have to then find alternatives for them for other medicines that are on the plan. But I think it's really important that some of the pharmaceutical companies this past year, as of June, and Dr. Kari and I have been talking about this for a lot of our patients, have now advocated that they will only charge patients $35 copay, in essence, for their inhaler. And so I've been paying attention to that a lot, talking to my patients, because sometimes patients won't tell you why they're not getting their medicines.
Oh yeah, it's hard to come out and say that.
And so it's important to talk to them about access and that medication, and that companies like AstraZeneca, Boehringer Ingelheim have now committed to that $35 copay. We hear GSK, the maker of Flovent in the past, will commit to that by next year. So we really want to get that information out there because we have to share that information even to the pharmacy, because I've heard some pharmacists, say, oh no, that's not true. Well, actually, then we advocate for our patients and say, take this website to them and show them that the pharmaceutical company is really committing to this. So that's ultimate what we need, is these medications to be affordable for our patients because they work.
So Leah, I understand you were impacted by this change. What happened when you tried to fill Flovent?
Yeah, so in early January, I tried to get a refill for Flovent, and my pharmacist called and said that Flovent was discontinued. So I called my daughter's primary care provider to understand what replacement we could use instead, and they instructed me to call my insurance company to see what would be covered. And it ended up being a headache. I had to talk to multiple people to understand what would be covered. And Flovent is what we ended up being prescribed, but it was pricey at first. I'm really glad, Dr. Castro, you mentioned affordability, because that was the first thing that crossed through my mind is, what do families do who don't understand how to navigate, just the healthcare system in general, much less changing medications, and then also how to address affordability. It has actually gone down since then, as noted, but it was difficult because with her inhaler now, because she's not old enough to suck in, we actually have to break the inhaler in half in order to administer it. And so the pharmacist didn't know that at the time, so I had to go to her primary care provider to have them show me how to do it. And I actually instructed the pharmacist how to do that next time she got her prescription done. So it was a learning curve at first, not the smoothest transition at all, but we figured it out, and QVAR works for her now.
And I just have to say, all of us learn from our patients. That's a great story, Leah. That's pretty impressive. So, okay, team, what questions do you wish that patients would ask you or families would ask you about dealing with their asthma?
Really, how to manage and navigate symptoms when they do arise, because a lot of pediatric patients don't have symptoms persistently. And so what is the contingency plans and what resources do I have in place beforehand to know my child has this nighttime cough all of a sudden? When do I need to give albuterol? So having an asthma action plan and a contingency plan is really important.
You got to really identify what makes an asthma exacerbation in a child, because they're not going to say to you, I'm wheezing.
Absolutely. So nighttime cough is really something that perks my ears up to know that, hey, this could be more than just a regular cough. It could be snowballing into something else.
What would you like to have people ask you?
I want people to ask me about things they can do to make their asthma better. Some of that is a conversation that happens between the patient and the physician, should be happening at every visit. Can you afford your medication? Are you taking it? What are your barriers to taking your medicine? What do you want to do if you have an athlete? If your athlete has been unable to participate in their sport, tell me your goals for your asthma management, because a lot of times they can loop back in adherence to their medicine. You want to play football? You want to be the best football player on your team? Guess what you need to do? You need to take your medicine. Let me help you do that so that you can get that college football scholarship.
I love that. Okay, so you may have questions. If you do, send them into the links in your screen on YouTube, Facebook, or email the Medical News Network. Dr. Castro, future of asthma therapy, what does it look like?
Well, I think it's an exciting time, and I say to my residents and fellows that are on there, asthma is a cool disease. I know cystic fibrosis is, Steve, as well.
I'm not sure either of us are cool here, but I'm just going to bring it up.
But it's, some of the new medications, we have now 6 biologics approved for the treatment of asthma. We suspect that there will be probably 6 more approved in the next few years. This has really given us an opportunity to do personalized medicine. We could figure out, what's triggering Charlotte's asthma, and then we could give you a medicine that has minimal side effects and controls that disease. And we weren't doing this before in our age, Steve.
No,
we were just getting
one instrument, man.
we were just
getting,
we were getting oral medicines that weren't working, that were just making them sick. So having this age now where we can actually do this personalized medicine and we can target the inflammation that Dr. Gear was talking about is really changing the lifestyle for our patients. Some of these medicines, we were talking about work-life balance earlier with Haley. Some of these medicines can be given every 2 months. So that means you can get down to like 6 shots a year. And some of the ones we're working with in terms of development, maybe you only have to take it twice a year. So that's going to be a game changer, for people like Haley that really have to work and have a lot of other priorities in their life. We have these medications, so ask your doctor about them. There are a number of them that are available. We see that they're very well tolerated, and the most important thing is that they avoid steroids. Steroids are a wonderful medicine when they were invented back in the 1950s.
They're still wonderful sometimes.
They're just loaded with side effects. It's estimated that about 2/3 of patients with persistent asthma get a burst of steroids every year. That's a lot of steroids out there being given, and we know those effects are cumulative. And so I unfortunately have had my pediatric colleagues, hand over care of an adult into adulthood of a patient that already has cataracts in their 30s, that have had bilateral hip dysplasia from their steroids. And so those are things that shouldn't be happening today in 2024 in modern medicine. And so we need to get our colleagues out there educated about the treatment of asthma. but also help our parents like Leah that really can advocate for their children and say, hey, is there a better medicine than getting these bursts of steroids 3 or 4 times a year? We can't accept that anymore. And I hope at some point in the National Asthma Guidelines we take away chronic steroids as any kind of treatment for our patients.
I like that. All right, well, let's check in with Doc Hawk joining us from Olathe this morning. Doc Hawk, we heard Leah describe Charlotte's experience with RSV. That was 2022, just 2 years ago. Since then, we have new ways to protect babies from RSV. Remind us what those are and how they work.
Yeah, I think we should say that we are thankful that we do have those new ways now. Just like you said, we want to protect those youngest among us, those under 1 year of age, particularly those under 8 months of age. And we do have 2 main methods to do that to help protect against RSV disease and hospitalization. And the first one is maternal vaccination. The mom getting vaccinated at least 2 weeks before birth is going to give passive protection with mom's antibodies to that baby when the baby is born. And this is a vaccine that you can get at your OB-GYN or probably even your primary care physician's office, maybe whoever is managing your pregnancy. And it is given between 32 and 37 weeks of gestation, and it's given during the time of September to January for those pregnant mothers. That will then give protection to baby for essentially October through March, essentially respiratory viral season, which does include RSV as well. It is very safe, and it does help protect and reduce the chance of baby getting RSV disease, especially lower respiratory tract disease. The next one is nirsevimab, and this is a monoclonal antibody, and we have heard about monoclonal antibodies for things such as COVID-19 infection or COVID-19. Nirsevimab is a monoclonal antibody directed against the virus itself. And this is a monoclonal antibody that is given to baby after birth. Especially if mom was unable to get vaccinated for RSV. And the actual recommendation is that all infants under 8 months of age who are born during RSV season or entering into their first RSV season, if get that monoclonal antibody if that birthing parent did not or was unable to get the RSV vaccine. The protective effect of that monoclonal antibody lasts approximately 5 months. It could even protect a little bit longer. And it is so vitally important because it has a significant impact. It is able to lower the lower respiratory tract disease by 70%. And also is able to decrease the chance that your baby will go to the hospital by approximately 80% if baby is infected with RSV. And I know that with those young children, especially those under 6 months and under 8 months of age, those airways are so small when they do get infection, especially with RSV, they just clog up a lot with all of those secretions that are being produced during that infection.
Dr. Sood, what do you think about some of these new RSV therapies? Are they going to help?
It's a game changer, and I hope in these next upcoming respiratory seasons in the winter time we see less hospitalizations because of it.
And you did with pediatric and adult asthma.
Correct. So we hope that maybe this might translate into less pediatric asthma, less adult asthma, and time will tell.
I love that. Okay, we know that many of you have questions. Let's head to Studio B, where Alexis Del Cid is ready and waiting for us.
We have plenty of questions. This first one is from Jill on YouTube. Jill writes, in the past, doctors have been reluctant to label children with asthma. That was the case with my daughter 30 years ago. Is that still the case now? They said struggles with insurance and other barriers.
So with the new healthcare guidelines, with insurance for all, that really has gone away. We want to make sure that patients are identified, diagnosed appropriately. So we will take the due diligence to make sure we're giving the right diagnosis so we can use the right medications. I think that some people may still not be diagnosed until maybe 5 or 6 when they lose that early childhood wheezing, we may call it, that is mostly viral induced. We recognize that that patient has gone past that they're wheezing outside of colds, that they're wheezing with exercise, or they're wheezing with animal or dander exposure or other sort of allergens, and then we realize this is probably asthma. But you have to take the whole clinical picture into account.
And not all wheezing is asthma.
Correct.
Absolutely right. And so if you have a 2-month-old with RSV or rhinovirus wheezing, it may not be asthma, but for some kids, they may grow into asthma over time. And so not all wheezing is asthma. It could be reactive airway disease.
All right.
I do think it's important for our parents, like Leah, to advocate for their children because unfortunately there are still children out there that are being treated these episodes of shortness of breath, coughing as colds.
Yep.
And they just get antibiotics, which is probably the wrong treatment, right? And so when you're
steroids.
Or steroids.
Yes.
I don't think you like those.
No, I don't like those. So when your child is having these episodes that keep happening over time, talk to your pediatrician about really, do they have asthma? Do I need to go see a specialist? And sometimes that advocating as a parent is really going to change that course for your child.
That's where family history is really important because if that child has a parent with asthma, maybe instead of antibiotics, a trial of something leading to a diagnosis of asthma can be helpful.
Marcia has a question. Marcia asks, can a person who hasn't had asthma previously diagnosed now as an adult start developing asthma when they start getting a nighttime cough? So she wants to know, is the nighttime cough possibly asthma?
So it's worth looking into. There are a lot of things that can cause nighttime cough, including reflux. So we want to make sure that we're going through all the proper steps to diagnose that patient with asthma, rule out other underlying conditions. There are lots of different testing that they can talk to their primary care doctor about, or perhaps a pulmonologist or allergist to see what is really going on before that official diagnosis is given.
Sometimes it's allergies, nasal drainage down the back of the throat that can trigger that nocturnal cough. So it's important, again, to address that with your physician and see what the treatment. Sometimes it's as simple as using a nose spray and antihistamine. We'll get that under control, but it's worth looking into.
Marie has a very good question for anyone who uses an inhaler. Marie writes, I have 2 inhalers. One says I have to rinse my mouth out every time after using it. The other one, I don't need to do that for. Why? What's the difference?
Well, I would say do rinse your mouth out after using any inhaler.
Who told you that?
In general, it's the steroid ones. The steroid-containing inhalers are the ones that we're concerned about. Using a spacer device helps you get the medication down into your lungs. I tell my patients, in the spacer that we saw earlier with Charlotte, that is so important to use because that slows the delivery of the medication and allows the patient to get it into their lungs where it works. I said, if you're going to spend this much money for a medication, you might as well get it to where it needs to be. A lot of patients, unfortunately, just put it in their mouth and it sprays on the back of their throat. And then they, if it's steroid-containing inhaler, they develop the thrush or yeast infection from that steroid. So rinse your mouth out, spitting it out, don't swallow it, spit it out afterwards.
I want to make one other point.
Please.
Dr. Castro makes a very good point. We have a lot of parents, a lot of patients think that using a spacer is only important in the childhood population, and that is not true. We would want everybody of every age to use a spacer with their inhaler because it does help get the medicine in the lungs as opposed to on the back of the tongue and throat where it does not belong. So any age, if you can use a spacer, please do so.
What I'm really hearing is that a drug that is designed to work in the lungs doesn't do as good a job when it lands on the tongue. Is that kind of all right? All right, this has been a great discussion. I am grateful to all of our guests for being here. I'd like to hear final thoughts before we go. Dr. Sood.
1 out of 3 hospitalizations for pediatric patients are related to asthma, and so
That's a lot.
the big theme today is really preventative care. Talk to your pediatrician. Really try to develop an asthma action plan to prevent systemic steroids and stay out of the hospital.
Yes. All right, Leah.
Yeah, I would say for any parents, you know your child better than anybody does. So if you think something is off, trust your gut and take your kid to be seen and continue to advocate, like has been mentioned already.
I think that's a great point. Advocate until you get the answer, right? Don't stop that. Dr. Garn.
have a good conversation with your physician if you can't get your medicine, if there are barriers to getting your medicine, if your medication is not working, if you're having side effects from your medications. We have so many different therapeutics now. We can change things if we need to, but you need to advocate for yourself with your doctor when it comes to getting your medication.
Yeah, that's a really big deal, right? And keep working so we can try to find ways to help you get those drugs. Haley.
I think just that there is hope that you can continue to live a normal life and you can grow out of it, well, to an extent, I guess maintain it. But also that does come with, appropriate medication adherence and access to the resources, so which I've been lucky to have.
Yeah, that's awesome. And now, Leah, does Charlotte have a last thought? Because I see her there. She's a gorgeous daughter.
Yeah. No.
All right, I like it. Yes. We'll take that. That's awesome. Dr. Castro.
Well, I have to advocate for really participating in research.
Absolutely.
And so one of the things that, these new medications that we have wouldn't have been possible without the research that we've been doing here at KU and other places to really discover whether or not these medications are effective and safe. And so I encourage everybody to go to the American Lung Association website. There's a lot of great information there. There's also great information at KU website where you can go to the pulmonary or the allergy division and learn about the studies that we're doing here. We have a lot of good studies that are studying new medications. And what I always tell my patients that participate in these clinical trials is that you're going to learn so much about your body and about your asthma or your child's asthma that you're going to benefit. Even if you got placebo, you're going to benefit. And that's the way that we're going to advance science for our patients.
Yeah, this has been a great discussion, and I love the way we've mixed in advocacy, science, patient care, and hearing directly from a patient's voice. It does take all of us to get this kind of great work done. And the more people get involved, the better our results are, because together we can do just about anything with that combination of faith, hope, and science. Thanks again to all of our audience. We'll see you back next week. Have a great day.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.